So good afternoon. And your chief residents asked me to talk about heart disease and health disparities in minority populations and underserving communities. I have no disclosures. Oh, this is not advancing. Did it advance?
No.
Okay.
Maybe if sometimes you need to click the first time before you use the keypad.
Just do new share. All right, so let's see what happens now.
So right now we see so we see both of the slides. So if you do display setting, swap presenter view.
Okay, how is that?
Hasn't changed right
okay
now.
So can you look on your phone and see what you're seeing? Okay, so anyway, I'm just going to keep going. There are no disclosures relative to this discussion. And today I was asked to use case presentations to enhance and implement what we're going to be talking about. And so, so I'll be punctuating the presentation with 3 different very interesting cases, which I hope, I may get some feedback with people texting in the chat. So obviously very important to this conversation is what exactly is a health disparity. So we'll talk about that, including implicit bias, and then why do we even focus? And then we'll talk about the difference in outcomes among groups and some solutions for achieving health equity for cardiovascular disease. So let's define health disparities. So a health disparity is a difference in outcome of health status among different people living in the same town, same city, same country, based on your status of your health and access to that healthcare, quality and utilization. And that is based on what you look like, who you are, your social status. So social, race or racism, ethnicity, your gender, income, education, where you live within that city. Do you live in the Bronx? Do you live in, the South Bronx or Central Harlem? Do you live downtown? Your geographic location is important, and your level of disability. And all of these should not exist. So it becomes fundamentally unfair in practice and design. And by that definition is a disparity, health disparity. So despite advances in therapies, new treatment options, people should, be having similar outcomes if you're able to control for all things. There are some studies that looked at hospitals that engaged in Get With The Guidelines that showed that actually with all the advanced therapies, new treatment options, and equitable care, the outcomes were similar, very similar for all racial and ethnic groups. But if that doesn't happen, you're going to have different outcomes. And so one of the big issues, obviously, is access, education, et cetera. So that's the issue that we face, and bringing more awareness, of course, will help to ameliorate that issue. And I just wanted to show you this slide.
Dr. Fergus, we are just seeing the disclosure slide. We are not seeing.
Say it again.
Slide. We just see the disclosure slide, so we're not seing the rest of the slide.
You're not seeing the other slides?
No. So maybe we can try to stop the share and share again and see if that helps.
Okay. Okay, tell me what you're seeing now.
So now I see both the first slide and the second slide. So if you go to display settings and swap the presenter view, that we should see just one slide probably. Display settings, and then if if you, yeah.
Okay,
if
what are
click
you
on
seeing
that,
now?
it just doesn't work for some reason.
Just a disclosure slide, right?
Yeah.
Okay, so again, okay, so I'm just going to go through these quickly. We talked about the objectives.
It's just not
I think you're
going.
still gonna be stuck there, but if you'd like, you can also send us your slides through our email account, and
And we
perhaps
can
we can
share
share
it
it for
if you
you.
want.
Sorry about that. I don't know what's happening.
I don't know why this is not working.
Yeah, maybe just if you go on the at the bottom on the right where there's the presenter, like at the bottom right, close to the percent.
Yeah, I did that already.
Oh, that wasn't working. Okay.
Or perhaps you can share it this way. We can see it better.
Okay, now we see the health
slide.
disparity definition slide.
Yes, okay. All right, well, there's not my intention to confuse you guys, but we talked about this definition, and we talked about the why. So you'll just have to see my presenter view as well as the slides, okay? Is that all right?
perfect.
Okay. So this slide, are you seeing the trends in US population?
Yes.
Okay, so I wanted to show this, the current trend in the US population and the projected trend. And this was actually, shared in the Journal of the American College of Cardiology by my colleague and friend, Dr. Clyde Yancey. And the reason is that we, definitely will be having more of a diverse group within the US. And in order to prevent a lot of like chronic issues where we're having chronic issues related to all of the challenges we face, we need to be able to address and attend these various populations so that they're having equitable outcomes and not ending up in our emergency rooms and clinics with multiple issues. But as you can see, currently the predominant population is a non-Hispanic white race. And then you're going to be seeing a big increase in the Hispanic group, as well as the Asian group, and 2+ races. So definitely to keep that in mind as far as our patients go. Now, I can tell you that there's still a lack in enough information or clinical trials that look at all of these different racial and ethnic groups. And most of the studies that we have now really compare Blacks, Hispanics, and whites. But, hopefully with, more awareness, we'll start to see more information relating to, the Asian groups and other groups. But let me just show you life expectancy among Blacks, whites, and Hispanics. So if you could look on my left, you'll see the bars that represent Hispanic, non-Hispanic white, and non-Hispanic Black. And interestingly enough, you'll see that the life expectancy is higher for Hispanics. That's a conundrum, right? Because with the risk factors, you would not necessarily expect that, but there's a higher life expectancy and we'll talk about why that might be, for Hispanics compared with non-Hispanic whites and non-Hispanic Blacks, which have the lowest life expectancy. And if you look at the figure on the right, you'll see that among everyone, the Black male has the lowest life expectancy compared with everyone else. But this better life expectancy for Hispanics, that's called the Hispanic paradox. And, and there's different explanations for that, but typically you're seeing in terms of the cardiometabolic risk factors, there are higher rates of obesity and diabetes. There are the social determinants of health. There's health literacy issues, et cetera. So there are potential explanations for that, which I won't have time to delve into. At the end, I'll show you a couple more slides on Hispanics, but there's some underreporting of deaths. There's also something called the salmon phenomenon where salmon, you know, with salmon, they go back to their place of birth, they travel back and forth. And so when you look at a particular area for salmon during a particular time, you don't really find them. So with it's also purported that you know, some of the Hispanic population, they'll go back to their homes to die, so they could be buried there. So they're not counted as much as they could be or should be within our morbidity and mortality data. And I just wanted to also point out, we said that we're going to be having, you know, you'll see that there's a bigger influx of Asian Americans within the US population. And so recently there was an advisory from the American Heart Association that states that the Asian Americans are the fastest growing racial and ethnic group in the United States, representing about 25% of all foreign-born people. So they're expected to reach about 34 million by the year 2050. And so we definitely need to focus on, you know, specific treatment arms for these groups. But this is not a monolithic group. There are 7 subgroups. You have Asian Indians, also known as South Asian, of which the Caribbean Indians are part of this group, as well as there's Chinese, Filipino, Korean, Japanese, and Vietnamese. And why is it important to separate the subgroups? Because when you look at the subgroups, you'll see that the Asian Indians or the South Asians, they have a higher rate of cardiac disease as their cause of death compared with the other groups. And so I'll show you a little bit about that. But what we're going to do is we're going to punctuate our discussion with some cases. So I want to talk to you about a case of heart failure. And let me just show you the projected heart failure prevalence here in the US. If you look at this slide, you'll see that heart failure prevalence is projected to increase over time. But it's projected to increase more in certain groups versus others. And the group represented in green at the top is Black. And in blue is represented white, non-Hispanic. And then red represents Hispanic, okay? Other would be the other groups that we talked about, which, you know, it's not as well defined because, again, we would have to break down among the groups, but suffice it to say that it's projected that heart failure will increase among all groups, but more so in the African Americans or Blacks. So let's talk about our first case. So this is an African American male with heart failure. He's 69 years old. I've been following him since 2017. When he presented, he had been following at an outside institution, and honestly, he was already at stage D, New York Heart Association class 4, meaning he was very sick at that time, and I was concerned that he wouldn't have longevity. But getting to know the patient, talking with him, getting him to understand his medications, getting him to try certain medications that he wasn't willing to try. Fast forward to 2021, 2022, and here we are. So he remained an active smoker throughout this time, smoking about 6 cigarettes a day. He already carried the diagnosis of COPD for about 10 years and pulmonary hypertension. He had high blood pressure, hypertension as well, and you're going to see that that's going to be important, so keep that in your memory. He has an ejection fraction that started out at 21%, which was a non-ischemic dilated cardiomyopathy. That's what he had. And that means that the cause of his heart failure was not due to coronary artery disease. When I met him, his heart was so big and weak, he had a thrombus in the heart. That was 2019. He also had a syncopal episode. When that was evaluated, it turned out that it was ventricular tachycardia. So with us, he received a single chamber ICD. He also had stage 3 CKD. At that time, his peak creatinine was 5. But after treatment, it came down to somewhere between 2.5 to 3. In further evaluating his kidneys, he had a non-obstructing calculus at the lower pole of the left kidney. Believe it or not, he had other issues. He had HCV, he had fatty liver, and he had renal cysts, as well as hepatic cysts and hydronephrosis. We treated him with the treatment for HCV, and HCV became undetectable. So he was doing really well. In fact, the good story about this is when we first met him, he thought he was going to die, so he wanted to marry his lifetime love. And he got married Valentine's Day 2019 and had been doing good. So he went from a New York Heart Association class 3 to 4, he was between 2 to 3. But as I mentioned, he continued to smoke. And then on top of that, he developed an infection around the end of December. And it was RSV, not COVID, but that, really debilitated him. And so he had several admissions after that. And fast forward now to March, April. So he was admitted several times, and he was started on milrinone. This last visit with me, I just saw him last week, he was asking to be tapered off the milrinone and that he would cut it off himself if we don't stop it. But when you asked him about his chief complaint, he said he was feeling weak and tired. And he did not ascribe that to his heart failure, but he's saying he's sitting around more and more in the home. He feels that he's deconditioned. He was also not taking some of his medications. For instance, you know that Entresto, which is valsartan, sacubitril, which is indicated a class 1A for patients with heart failure. He wasn't taking that, he said, due to cost. And then he was still smoking at times. So here are the medications that he came in on. As you could see, there are multiple medications. And might I add that as part of one of his recent hospitalizations, he went into atrial fibrillation, which was probably due to volume overload. And so he was started on amiodarone. Amiodarone was to slow down the heart rate for the atrial fibrillation because there's so many multiple issues. We knew that it wouldn't, cardiovert him out of AFib, but it was to keep him in, at least rate controlled. And then he was on apixaban, which is Eliquis for the AFib. He was on other GDMT, including the beta blocker and the statin, and on other heart failure meds, which would be the spironolactone and the diuretic, in which case he was on torsemide. And as you know, now we're treating with certain medications such as dapagliflozin, which improves heart failure readmission rates. So he was on that. But as you could see, he's on milrinone because we tried to taper him off of that, and he developed, worsened heart failure. So he had to go home on the milrinone. This was his last, physical exam in the office. He actually had a decent blood pressure because typically he's high, he runs very low blood pressures. And so it's very hard for him to, take medications. He was actually saturating well with a good pulse, still in AFib, gained some weight, which may have been water weight, but when I listened to him, he didn't have any rails or he wasn't using accessory, muscles. He was warm, no edema, no cyanosis at this time, but in the hospital, he was cool. His extremities were cool, and he was not perfusing. That was one of the reasons he went on the milrinone. This is his chest x-ray. Can you put in the chat if you think what do you think this chest x-ray shows? Just, quickly, or if somebody wants to tell me, they could go off mute and tell me what the chest x-ray shows. Or you could put it in the chat. Anybody? Okay, so you'd put, is this a normal chest x-ray? Okay. Cardiomegaly, okay. Very good. I'm seeing cardiomegaly. I'm seeing left-sided effusion. Very good. What else? What else do you see? you may see, do you think this guy is volume overloaded? Say yes or no. That's right, interstitial edema. Well, someone even said mild to moderate congestion. Wow. Well, he has congestion, and he has curly B lines, which shows longstanding congestion. So yes, he was, very volume overloaded in his chest. He was cool. So we thought, what's going on? We've diuresed him. His BNP went down from over 10,000 to 2,000. So we were trying to figure out what's going on. So we did a right heart cath. So to your right, you see the right heart cath results. And you could see that he had a significantly decreased cardiac output and cardiac index with very, very high filling pressures, high pulmonary capillary wedge pressure, high right ventricular wedge pressure. So we recognize that this patient needs to be on medications to improve his cardiac output. So he's on milrinone. Is there any other treatment, like a mechanical device, that you may offer to this patient? Can you put in the chat if you think that yes. Yeah, he has, okay. Right, okay. You guys are really, really smart. You're really, really smart. So this is a borrowed, his x-ray looks just like this with the ICD, absolutely. So, this one projected better, so I put that, but he does have a single ventricle ICD. So what other devices or any other treatment that you may want to give to this patient to help him, since he's so weak and debilitated and he's been living so many years? Is there any other device that you may want to give to this patient? If you could think of something, put it in the chat. Okay, someone said cardiomems. Very good. Anything else? Well, in the interest of time, I'm going to go on. Yeah, so he could get a LVAD. So that's a ventricular device, right? Very good. Eric said that, mentioned that. So a ventricular device, also known as a mechanical circulatory support device, is an implantable mechanical pump that helps to augment the function of the left ventricle and increase cardiac output. And people live longer, feel better, improve quality of life, 3.2 to 10 years longer than people who don't receive the pump. So in this next slide here, you could see I am highlighting here in the middle the differences in this study review on LVADs, and you could see that males are more likely to have the device compared with females, more likely to be in whites compared with Blacks and Hispanics. But it's a high utilization rate in Blacks, so they're usually sicker and they would do better with this. I'll provide the references for this to your chief residents. I apologize, I was doing this quickly and I didn't have references on all of them, but this is there. And you can also see that if you have a Medicaid type of insurance, you're much less likely to get it. So if you have Medicare or primary insurance, you're more likely to get it. So in summary here, whites accounted for the majority of LVAD recipients, although the utilization would have been higher in Blacks, meaning they would benefit better for it. And Medicare was a predominant primary payer. So if you have something like, no insurance or Medicaid, you're not likely to get it. So in this slide here, I just wanted you to show that if you look at Black men, white men, Hispanic men, and corresponding women represented here in the various colors, in mostly all of the cardiovascular diseases, Black men and Black women have a higher prevalence of CVD, stroke, and heart failure here on the right in the middle compared with the others. And usually that's because of hypertension, but there may be other reasons as well. So if you look at hypertension, it's higher in African Americans, almost double that in whites. And this next slide shows the hypertension among the groups here. And again, in the middle, you'll see that Black males and Black females have a higher percent of hypertension. And the reason why I say that is that the most common cause of heart failure is coronary artery disease or hypertension. And in Blacks, it's typically hypertension. So when we talk about blood pressure control, that's important because you want to, that's a precursor for hypertension. So you may ask, well, are they aware? You know, are they on treatment? And what about the control? So in this, you know, figure that you could see here, you see non-Hispanic white male and females, non-Hispanic Black, Hispanic, and actually this one includes Asian, right? And you will see that actually, you know, if you look at Blacks, they have a pretty high awareness of you know, of having hypertension. What is it about? What does it do? You know, the awareness is represented in the blue bars, right? And you could see that, you know, the Black females in particular, they have the highest awareness about, you know, hypertension, right? In terms of treatment, you know, most of these, you know, groups, they're on treatment, but, you know, not controlled. So that tells you that hypertension alone is not the issue. There's other things that we'll talk about that contribute, such as we'll talk about later, social determinants of health. But suffices to say that even with being on treatment and awareness, when you have hypertension, the Blacks have worse outcome, higher prevalence, number one, but they'll have more of end stage, you know, outcomes like higher risk of non-fatal stroke, 1.3 times, 1.8 times greater risk of fatal stroke, 1.5 times greater rate of cardiovascular death, and 4.2 times greater rate of end-stage renal disease. So back to our patient. This patient, when he came in to see me, as I said, he wanted to get off the milrinone, right? I sat and spoke to him, and remember, we have a good relationship pretty much, but he wanted to get off the milrinone nonetheless. So which of the following factors do you think may be contributing to the patient refusing to continue life-saving medical treatment, in this case, milrinone? Ineffective communication, low health literacy, cultural health beliefs, bias of the healthcare team, the first three, or all of the above? Can you put in the chat what you think? Why is he refusing to be on the milrinone? You could just put A, B, C, or D. E. Somebody, okay, everyone's putting E. Okay, well, I agree, because clearly he needs to have more conversations. And just to tell you, he had a conversation with palliative care. We had social worker and everyone involved. But in patients like this, there needs to be ongoing education and also communication about end of life, which we had. But you know, he due to his part of it, one of the strongest thing in him was his cultural health beliefs. So as a Black male, you can't appear to be you know, weak or not a provider. And he later confessed to me that wife that he married on Valentine's Day, he was very much afraid that he wasn't providing for her. He didn't want to look weak. He couldn't do some of the same things that he used to do. And because of that, that's why he wanted to get rid of the milrinone. So you have to have this conversation and then, you know, involve the family members, etc. I'm going to speed up a little bit because where time is going by, but keep that in mind. So the question number 2, they told him he's not a candidate for the LVAD. Okay. Now they had a long conversation with him, and initially he was saying he didn't want the LVAD, but he clearly needed the LVAD. And then he got really sick to where now he's told that he's not a candidate for the LVAD. So all that is available to him is now the milrinone. So which of the following are contributing factors in the patient not getting life-saving medical treatment, which is the LVAD. Can you guys put A, B, C, or all of the above? What do you think? So the answer is ineffective communication, low health literacy, cultural health beliefs, bias of the healthcare team. What do you think would be the answer? Okay, everybody is putting E again. And again, this is a discussion point, right? So everybody's right. The cultural health beliefs initially, he didn't want to have the LVAD because he didn't want to appear to be weak and needing a device. But he also has low health literacy. He doesn't understand his medical care. And of course, bias of the healthcare team. They figure, you know what, he doesn't want it. We're not going to try and, push it on him, but ultimately it would save his life, right? Or give him more, longer years. So that is correct. So let's move on quickly now. We're going to talk, I just wanted to bring this to mind, the social determinants and structural determinants of health. So that includes multiple things. And as a physician, you all need to look at, besides just the clinical care, look at other, potential contributors to your patient's outcomes. So here you see a little doctor on the bottom looking with his microscope for the key to the disease issue with his patient. And he can't find it. And the two little cats are saying, why is he looking at risk factors and behaviors when the key lies in social determinants? And here's the devil holding the key with, some of the social determinants, which are things like poverty, access to care, environmental exposure, racism. This should include education, literacy, etc. So I want you to keep this in mind as we continue our conversation. So our second case is much less complex, but again, this keeping in mind social determinants, for instance, I wanted to just share this. So this patient is an Asian female, South Asian, but she's a South Asian from Guyana. And she comes into clinic with follow-up for treatment of her diabetes, lipids, and hypertension. We prescribed the PCSK9 inhibitor several months, and every time she comes back, she's not on the PCSK9 inhibitor, okay? And I'm gonna kind of speed through this, but she has a family history of hypertension, her social issues, her husband died early, so she raised her children by herself. On the next slide, you'll see that her weight is 176. Otherwise, she is doing well. Her blood pressure actually was good, and no physical findings on exam. These are her medications. So you could see, she has diabetes, hypertension, dyslipidemia, being overweight. So these are all her meds here. She's on pretty good meds, the ones that she decided to take. She's on management for her diabetes, and she's on management for her blood pressure and also for her lipids. So she's taking the Trulicity, the Victoza, and the metformin, and she's taking the atenolol, and the furosemide, and she needed some potassium. But for her lipids, she was taking the Tricor, and she was also taking the Crestor. So she's on her statin, but she still had uncontrolled lipids, which I'll show you here next slide. And this may not be projecting very well, but her total cholesterol highest was in the 230s. Her triglycerides highest was in the 400s. Her HDL was decent, but her LDL in a patient like this should at least be less than 100. We did a calcium score and she has 0 calcium. So according to the American Heart Association, American College of Cardiology guidelines, you want to have an LDL less than 100. And so, but if she had CAD, then we would aim for less than 70. But be that as it may, being on the Tricor and the Crestor, she's at 100. And so we want to 106. So we want to go to adding the PCSK9 inhibitor. And her non-HDL is also elevated in the 140s to 150s. So another reason for being on the PCSK9 inhibitor. So She kept on not taking it. Then after, discussion with her, we're saying to her, well, you know what? You're not at optimal medical treatment. So again, this is a very quick case. So I quickly want to find out from you guys, because you see this in clinic all the time. What do you think is contributing to the gaps in her care? Is it social determinants of health, cultural beliefs, bias of the healthcare team? Which one? Or is it A and B? All right, so I don't know if you guys can just quickly put in your chat, but social determinants of health is, again, who you are, where you are, where you live, what access do you have, etc. I found out that the reason she wasn't taking the PCSK9 inhibitor, we had given her several samples, but do not assume that your patients can actually get the medications. It turns out that she had a very high copay, a very high, initial payment. And so she did not have the money to get that. So even though she got started on it and we had some improvement in her care, she wasn't able to continue. So that was the reason. So social determinants of health and non-adherence in this case is due to that, not necessarily because she didn't want to. Okay, so I'm going to keep on going here. Just talking about Asians and CAD, as I mentioned, it was a rapidly growing component of the US population, higher prevalence of insulin resistance, elevated CRP, lipid disorders. This slide shows that we don't have a lot of data, but the data is increasing. We'll have more data, but you'll see that the rate of CVD death rates compared to US whites is increasing. And again, it's a breakdown among the different groups, subgroups, and you can see that the Asian Indians, at least on the top for the females, that is increasing very rapidly. It's an increased slope, so we need to make significant interventions into this group. And here is another slide that talks about the prevalence of type 2. And again, type 2 diabetes, you would think that this would be more with the Latino group or the African American group, but lo and behold, you'll see, and this is a study of over 2 million adults in the Northern California Kaiser hospitals. And you'll see here that actually the South Asians, Pacific Islanders, and Filipinos have a higher prevalence of diabetes. So again, don't make assumptions based on people who they are, but really look at the data and quickly, make analyses and read about it. This is another slide here that looks at individuals who do not have manifested CVD, and they don't even have type 2 diabetes, but they have the metabolic syndrome. As you know, the metabolic syndrome is a precursor for cardiovascular disease down the road. And here you look at 3 different major organizations, NCEP, IDF, and World Health Organization, and comparing Caucasians, Filipinos, and African Americans. The Filipino woman was more likely to have metabolic syndrome. So again, don't make suppositions just because you see this woman who looks tinier and less weight that they don't have risk factors such as the metabolic syndrome, which may become an issue. And in fact, on this next slide, I'm showing you a Filipino woman and an African American woman. On the left is the African American woman, on the right is the Filipino woman. She weighs 115 pounds. The African American woman weighs 160 pounds. So you would think that this woman is more at risk just based on the weight. Again, you've got to really, analyze and dig a little deeper. Visceral adipose tissue is a risk for cardiovascular disease. And when you look at the 2 women, this Filipino woman tends to have or shows more visceral adipose tissue at 84 centimeters cubed compared with 25.4 for the African American. So again, no cookie cutter approach. You really need to take a look using the data, but looking at all of your patient populations and figuring out what is higher risk in these groups and managing them. So this next slide actually shows, again, comparing Filipinos, Caucasians, and African Americans with their BMIs and the risk of visceral adipose tissue. So the Filipino woman is represented in yellow, the Black or African American in brown, and Caucasian in blue. And as you can see, at all waist circumferences, the Filipino woman has a higher visceral adipose tissue compared with the Black and the white, female. So just keep that in mind. So just a quick little summary on managing CVD in Asian Americans. BMI fails to account for differences in fat distributions, a greater proportion of body fat, including those who are relocated or living in the Caribbean, in the Chinese, Filipinos, and Asian Indians compared with whites and other racial groups. And this is an independent risk factor. Don't look at just, the total weight, but look at other measures and consider other examinations in terms of looking at predisposing risk factors. They also have a higher mean calcium score compared with whites, Hispanics, and African Americans and other Asians, especially the South Asians at a younger age. And you may think, oh, they're protected because they don't have as much hypertension. But in this group, you want to do calcium scores. And that's what I do to figure out like how aggressive to be with these patients. Okay, moving right along to our last case. This is a sad story, but this is a Nigerian young immigrant with significant cardiometabolic risk factors. He had hypertension, diabetes, paroxysmal AFib. He status post cardioversion here at our own institution. He has sickle crisis. He had some AFib before and was cardioverted at an outside hospital where they put in a Foley. They caused a urethral tear. It ended up leading to hemorrhagic and septic shock and cardiac arrest in this patient and during 2016, and he stayed there for quite a long time. At any rate, he recovered from that and continued to follow at Sinai. He had unprovoked leg DVT in 2019. In 2020, we did a stress test and a cath because he and his wife, they were thinking of having children, and we wanted to make sure that he was doing well and that we could harvest, do the procedure to harvest, sperm from him for them to have the child. At the last visit when I saw him, he was walking about 2 blocks, limited by pain in the left hip because of his sickle cell crisis, but also because he had a fracture of his great right toe and a tear of the plantar fascia, which occurred in February 2021 after fall. Also, I should mention that he had like a congenital smaller right lower extremity, which also, contributed to his mobility. So he was doing well. He and his wife actually worked at this particular hospital where all of those things happened to him. But the one thing besides the hypertension, diabetes, AFib, he continued to smoke and drink, okay? At any rate, remember I mentioned that we did a cardiac cath when he appeared to be ill. Well, this is his cath showing the left coronary on the left and the right coronary on the right. He had a large V wave and PCW, but otherwise the cath was normal. These were his meds when I last saw him. So he was on dronedarone or Multac to keep the AFib, to keep him in sinus rhythm. Other cardiac meds, he was on the apixaban. He was on metoprolol, 125. He was on Janumet for the diabetes. He was on Zetia for the lipids, okay? So he presented with significant chest pain to that same outside hospital because they lived near that hospital in Brooklyn. He was admitted with chest pain and shortness of breath. The family were afraid of being there given their past experience. And the wife actually called me up to see if I could transfer the patient because they were very, very nervous. But they found out that it was mainly due to sickle cell. And so I couldn't transfer him to, my cardiac care. So he continued to have pain. There was frustration expressed by the family to the point where then they decided to give him some really strong narcotics. He became confused and walked off the floor and ended up in an office at the hospital. He was brought back by the hospital police, sedated. He was sedated to the point where he ended up having respiratory compromise. He was intubated, and he subsequently, within a couple hours, underwent cardiac arrest, and he died at age 48. Okay, so which of the following contributed to the patient's untimely death? Lack of trust in the medical team, implicit bias, lack of or appropriate medical treatment planned for this particular patient, or that should be lack of appropriate medical treatment for this particular patient. So if you want to quickly put something in the chat, what you think it is, was it lack of trust in the medical team? Was it implicit bias on the part of the medical team? Was it lack of appropriate medical treatment? Is it A and B or all of the above? And so if you want to put that in the chat quickly, I know we're running out of time, but I would say that it's all of the above, including lack of medical treatment. They were supposed to give him the appropriate medical treatment for his, because he's a sickler. And typically when people come in, they're either not given the pain treatment and then they really decompensate, or they give them too much. In this case, the patient ended up having a respiratory and then a cardiac arrest. The other thing is they had a lack of trust in the medical team. Remember, this was the same hospital where he was admitted for quite some time, was intubated. They did, you know, he had some bad outcomes. And then there's implicit bias. So implicit bias is where I'll define on the next slide. It's thoughts or feelings. You yourself may not be even aware that you have these feelings. This is different than racism, because racism is where you deliberately, you're not giving or not doing something because of what someone looks like. Implicit bias is where you actually have that feeling, but you don't even know that you have that feeling. But you kind of think that, you know what, this person's probably just trying to get, you know, more medication. I'm not going to give him. Or then you're going to say, you know what, I'm going to give him, but I'm just going to give him too much. So you're not even aware of the feeling. So rather than being neutral, there's a preference for or aversion to a person or group of people. And again, it's having certain stereotypes without our conscious knowledge. So this was implicit bias, and this probably played a role on for this patient. So quickly, I'm just going to quickly mention, we talked about the Hispanic Americans, and we'll leave that for another discussion. But again, to say that you just don't lump all the Hispanic Americans into one group, because, you know, there's Cuban, there's Central and South American, Mexican American, Puerto Rican, and some of the groups have higher risk of certain things like, and worse outcomes for certain things like type 2 diabetes compared with the other groups. Like for instance, Mexican Americans and Puerto Rican Americans tend to have a higher prevalence of type 2 diabetes and worse outcomes. So I'll provide these slides, just a few more slides and I'll be done, but these are all the barriers to optimal treatment. Some are patient related, some are physician related, and some are systems related that you could see here. Some of them we discussed, such as low health literacy, cultural beliefs, doses, lack of trust, and so on. Pride on the patient side, on the physician side, communication barriers, implicit bias, things like that. And the systems related is not having enough time sometimes in your clinic to really talk to these patients and get to find them out. I don't have time to talk about clinical trials, but they need to be representative of all patients so that we know that the treatment that we're giving to our patients is truly reflective of who they are. Health literacy, of course, is a big issue. And let me just mention that almost half of patients with hypertension or diabetes had an inadequate health literacy and really did not know the extent of the disease and how they can make you know, an impact with lifestyle and management skills. So be sure to ensure that you're providing adequate enrollment. And then I just wanted to mention that also the healthcare providers of some of these patients with the highest risk, we need to have more within the US. The Asian American groups, actually, the Asian groups, they're very highly represented compared with the current population, but African American and Hispanics are underrepresented for both just primary care and also cardiology. So at the end of the day, your patient is the center, and you are the healthcare provider, but ensure that you help the patient in all these respects, if you could, by communication, by finding out what's happening with the family, the community, and of course, engaging the healthcare system to provide the best care, because you're the advocate for your patient, and you can really work with the patient and the team to ensure that the patient is actually actively engaged in their care. And this positive repetition means even if you said it to the patient once, continue to, because you could, as you could see with some of the patients, we've said it, we've talked about it, and then they still had certain, beliefs or understanding. So you need to continue to, positively reinforce the things that they need to know about their healthcare. And so the bottom line is that, despite all of the advances, unfortunately, we have rates of reduction in disease, death rates, and morbidity that is less steep for minorities. Some are less likely to receive cardiovascular testing and appropriate care, and the awareness has plateaued. So we need to continue to educate these underrepresented minorities. And I'm going to end with this slide that shows what's the difference between equity and equality. Without having the accurate or adequate care, you're going to end up with disparities. Equality is giving everyone the same thing, whether they need it or not, which is the first window. So the tall boy doesn't need it. The little boy actually needs it. They all don't need the second box. Equity is the second bar where the little boy, the littlest one, got the 2 boxes, and now they can all look over the fence together and enjoy the game. But reality is that that tall boy who doesn't really need anything, he has 7 boxes, and the little tiny kid has nothing. In fact, he's dug into the hole. So we have to continue to do conferences like this and awareness so that in the end, there's just liberation and there are no barriers. The barriers are taken away so that you don't even need to actually give crutches to individuals and they can enjoy the game without those crutches. So I'm going to end there. And I think we have like 2 minutes for questions. So I'm going to stop right there and ask questions. Any questions? A lot of information. Typically, you're covering this type of topic in a whole entire afternoon. I tried to get as much information as I could, but do we have time for a few questions?
So before there's questions, I just want to say hello and thank you so much for sharing your knowledge with the residents. It's always a pleasure to have you.
My pleasure. Thank you. Thank you.
I have one question. Thank you so much for that. Just in terms of what we can tell our patients, does the visceral adipose tissue sort of respond in the same way to, diet and other lifestyle modifications that subcutaneous adipose tissue does with change in, I guess, ethnicity or genetics?
That's correct. So you can begin to mitigate because, this is going to, over time, untreated, you'll begin to coat arteries with fat and atherosclerosis, and it's going to increase, the plaque. So yeah, one of the things you do to begin to mitigate that is to manage these cardiometabolic risk factors with the lipids, with the diabetes, with the weight, and obviously nutrition and changing diet is very, very important in these groups. And in fact, I'm working with one resident where we're and my team here at Sinai, where we're looking at possibly introducing something called My Thali or My Plate, where, even if someone's a vegetarian, they're going to be, we'll be showing them ways to eat more non-meat foods that are lower in lipids and lower in fats and sugars, which would be helpful at reducing fats, including helping to address these visceral adipose tissue deposits as well. But of course, it takes time. And we know that, even if you look at, for instance, plaques in the carotid arteries, and we look at that. So there's some studies that show adequately controlled lipids over a long period of time. You may have some plaque regression, but at least you're not going to have a building of plaque if you maintain, the lipids at, in this case, less than 70. So if someone already has visceral adipose tissue, it's going to be hard to reverse it, but you want to be very aggressive with all of those things, the sugars, the lipids, but also the lifestyle and nutrition, as you just talked about.
Thank you.
You're welcome.
Thank
Any
you
other
so much,
questions?
Dr. Fergus. Do you guys have any question? You can also put it in the chat.
And I'll be happy to provide, the slides if you would like. And, if anybody wants to reach out to me, I will put my email in the chat because I know, the time is short. So happy to, discuss further or talk with anyone who wants to discuss further. So isilma.fergus@mountsinai.org.
Can I ask a question real quick? And I don't know if you addressed it, but I think there's a big push to try and say race, ethnicity now don't matter. It's all kind of equity and other issues. And I think, there's a lot of questions whether we're really going to say that genetics don't have a component on certain things. And I wonder if you might comment on that a little bit, because it's like a hot topic right now.
No, absolutely. And I would really want to give it the discussion time that it's deserved.
Sure.
But I would say that, yes, there are clearly, genetic dispositions to multiple, of these, comorbidities and cardiac diseases. But on top of that, so you'll have people with very high genetic risk. But on top of that, you have to ensure that the other components are very, very significantly managed and aggressively managed, because, people are already predisposed. So you have to go then above and beyond with the treatment. And so, for instance, having somebody with, say, familial dyslipidemia and their LDL is 160, right? So I know that this person, I have to very, very critically manage. I'm not just, going to, get them on therapy, but all types of management, including their family, if they want to have, children, so that it goes to the next generation, that there's awareness. And, even, you want to really have these conversations. In these patients in particular, I may do more testing, so in someone young, and I've had young people with this, for instance, genetically familial dyslipidemia, for instance, and what I would do is I would help them to get all the testing, including cardiac coronary CT, which often people have to pay for.
Right.
But you work with them and to try and get them all of these diagnoses, so you really know, sort of what you're dealing with. So yes, there's a genetic risk, but on top of that, you've got to be, super aggressive, really make the diagnosis, see what's there, and treat that, and then go above and beyond to look at other, possible contributors that are not just genetic, that would, hasten, them for having, a cardiovascular occurrence.
Great. I mean, it's almost a different way for us to think about it, right? Instead of saying this is a so-and-so Hispanic or white or something, we have to get in the thought of thinking with the genetic predisposition for this, and then say, and here are the social determinants that are heightening the risk as well, and really change the way we think about and present patients in the beginning, which is really hard, right? Because we've all been trained in a very, formal way to do it this way, and we got to really start to change our thinking about it.
Yeah, and that's why it's a team effort. So in my last slide, you as an advocate, I would just ensure that, you have other teams on board. So for instance, I work with the heart failure group, I work with the genetic group, I work with other teams. We have a team-based approach so that the patient's not falling off the track in other ways. Because, like the patient that I have, the South Asian patient, why isn't her LDL going down? She wasn't getting the Repatha. We gave her, some samples, but she couldn't get it. And nobody was discussing it. So she's coming and you're scratching your head, what's going to go on. And it's just, she wasn't getting the Repatha. So, in having that conversation and then being able to get it. So she subsequently now has an LDL of 69. So that's a good thing. Yeah.
Great. Thank you so much.
You're welcome. Thank you.
Thank you so much, Dr. Fergus. Thank you for sharing your contact and for being with us today. See you hopefully next year as well.
All right.
Absolutely.
Thank you. Have a great rest of your conference. Bye-bye. Bye.
Okay, guys.